Welcome to our rapid review on neonatal seizures. This is built from the ground up for the busy EM registrar, especially for those of you in Australia. Let's jump right in.
Okay, picture this. A seizing neonate just rolled into your ED. What do you do first? This is probably one of the most stressful situations you'll face, right? So let's break it down step by step. The first moves, the key investigations, and how to manage it all.
All right, Section 1, your first moves. Before you can even think about why this is happening, you've got to stabilize the baby. Let's talk immediate priorities.
So, what are those priorities? It's simple. First, your ABCs. Get the baby into the left lateral position, slap on some high-flow oxygen, and have suction ready. Next, and I mean immediately, check a blood glucose. Don't wait. And third, you've got to get access, IV or IO, whatever you can get, because you're going to need it.
Okay, the baby is stable for now. So let's move on to Section 2, uncovering the why. What on earth is actually causing this seizure?
Now have a look at this. It's really important to know the main culprits. The biggest slice of the pie, by far, is HIE. That's hypoxemic ischemic encephalopathy. But right behind that are the things we can often fix: metabolic problems, infection, and of course, intracranial bleeds.
And this brings us to probably the most important distinction you need to make. Yeah, HIE is the #1 cause overall, but in the ED, the #1 treatable cause is hypoglycemia. This is your chance to be a hero. You can find this and fix it within minutes.
Now, this is crucial. You've got to throw away your textbook idea of what a seizure looks like. A full-on generalized tonic-clonic seizure? Super rare in neonates. Instead, a whopping 70% of them are subtle. We're talking weird eye movements, lip smacking, little cycling movements with their legs. Even just stopping breathing, apnea, can be a seizure. You really have to be looking for it.
Right, on to Section 3, essential ED investigations. So what test do you actually need to order to get to the bottom of this?
Your first-line bloods are all about hunting for those quick fixes. So you're going to want a full blood count, a formal lab glucose to back up your bedside reading, and a full electrolyte panel. Don't forget the calcium and magnesium. And of course, a blood gas to check for acidosis and see what that lactate is doing.
And look, if there's even a whiff of infection, the baby's febrile, cranky, not feeding well, you have to do a full septic screen, no shortcuts. That means blood cultures, a urine sample, and yes, a lumbar puncture, but only once they're stable enough to tolerate it.
So what about imaging? Your first-line go-to tool for looking at the brain is a cranial ultrasound. Honestly, it's perfect for the ED. You can bring the machine right to the bedside, there's no radiation, and you can do it again if you need to. It's fantastic for finding the big, scary stuff, like bleeds or hydrocephalus.
All right, Section 4, the anticonvulsant ladder. We've got our investigations going, but the baby is still seizing. How do we make it stop? It's all about a structured, step-by-step approach.
And here it is, the Australian escalation pathway. Your first shot is midazolam. If that doesn't work, you don't panic. You move to step 2, phenytoin, and remember to give that one as a slow infusion. Still seizing? Okay. Then we escalate to our third-line agent, which is phenobarbital. It's a clear plan to follow when things feel chaotic. So stopping the seizure itself is huge, but it's really only half the battle. Now we get to Section 5, treating the underlying cause. This is where you can really change the outcome.
Let's say you found hypoglycemia. This is the best-case scenario, because the fix is so quick and satisfying. Your magic number, your target BSL, is anything over 2.5. You'll give a quick IV bolus of 10% dextrose, and then you'll start them on a maintenance infusion to keep it there. Job done.
What if it's hypocalcemia? Well, the treatment is an IV bolus of 10% calcium gluconate, but you have to be careful with this one. You've got to give it slowly. We're talking over 5 to 10 minutes, and you absolutely must have them on an ECG monitor to watch for bradycardia. And here's a pro tip. Always check and fix the magnesium level first, because low mag can cause low calcium.
And for suspected sepsis in a bug under 2 months old, the standard Aussie protocol is a combination of cefotaxime and benzylpenicillin. This combo gives you great coverage against the big 3 baddies: Group B strep, E. coli, and listeria.
And finally, we're at Section 6, exam pearls and pitfalls. This is the stuff you absolutely have to know, not just for your exams, but for your next shift. Pay close attention to this part.
Okay, first big exam pitfall. Write this down. Never ever use ceftriaxone in a neonate.
Why? Because it kicks bilirubin off albumin, which can lead to kernicterus. The right answer, the safe answer, is always cefotaxime. Always. Here's another one they love to trick you on. Do not give dexamethasone for neonatal meningitis. Steroids just have no proven role here. You only start thinking about Dex for meningitis once a child is older than 3 months. For newborns, it's a hard no.
I want this quote to be burned into your brain. Apnea in a term neonate is always abnormal. Look, preterm babies can have apneas. That's different. But if a full-term baby stops breathing for any significant length of time, that is a massive red flag. You have to investigate it, and you have to consider that it might be a seizure.
If you forget everything else from this talk, please remember this one number. Greater than 2.5 millimoles per liter. That is your target blood sugar. It's the number that protects that tiny brain from hypoglycemic injury. 2.5.
Okay, let's wrap it up with the final takeaways for your next shift. 1. HIE is the most common cause, period. 2. Hypoglycemia is the most common treatable cause, the one you can fix. 3. The biggest risk factor for sepsis, low birth weight. And 4. Don't forget, these seizures are sneaky and subtle. Keep your eyes peeled.
And that's a wrap on our rapid review. Hope you found that useful. Now, we want to hear from you. What's another critical EM topic you want us to tackle next? Drop your ideas in the comments below. And hey, if you want more of this kind of high-yield content, make sure you like and subscribe. Stay safe out there.